Welcome back, everyone, to the Deep Dive. And a special welcome to the abnormal psychology students over at LACC.
Yeah, welcome.
You're hitting Module 9 in Professor Segi's class, which, wow, this is a big one. We're talking about some really fundamental stuff today.
Absolutely. Intimacy, identity, sexuality.
Hmm.
These are core human experiences.
And often, things people really struggle with, maybe silently, it's personal.
Incredibly personal. And that's why understanding this module isn't just academic. It's about empathy. It's about connection. Especially crucial knowledge for anyone navigating relationships, identity, life stress here in a place like LA.
That's really our goal here today, to give you a kind of deep, empathetic foundation for these intimacy issues. We're pulling out the key insights from the module.
Yeah, we're looking at identity, sexual function, or, well, dysfunctions, and also what the module calls atypical behaviors or deviations.
I want to make sense of it all.
And what's fascinating here, I think, is how much of this module really hinges on distinguishing just normal human variation from actual clinical distress or impairment.
That line seems critical.
It is. The threshold for a disorder often isn't the behavior itself, but whether it causes significant distress or problems in life, or, crucially, harm to others. That's the core clinical challenge.
Okay, let's unpack this then. So before we jump into the clinical side, the diagnoses and all that, we need the basics, right? The language.
Right. Foundational language.
The module starts by differentiating human sexuality itself, which is huge, covering attractions, capacities, expression.
Influenced by everything, really.
Yeah.
Biology, emotions, social context, culture.
Yeah.
It's a mix.
Yeah, differentiating that from, say, sex assigned at birth or gender identity or sexual orientation. They're related, but not the same thing.
Exactly. Keeping those concepts distinct is step one. It avoids a lot of confusion down the line.
And speaking of the biological side, we should probably touch on Masters and Johnson, their four-phase model.
Oh, yeah, the human sexual response cycle. Still fundamental. Excitement,
It's plateau.
orgasm, and resolution. And it applies across genders, broadly speaking.
It's not just a biology factoid, though, is it? Understanding that cycle is important for figuring out what's going wrong clinically.
Spot on. If you know the typical cycle, you can better identify where the disruption might be happening. Is it a problem with desire, getting to excitement, or maybe arousal, maintaining that plateau, or reaching orgasm?
Knowing the phase helps narrow it down. Makes sense.
Definitely. Then moving more into identity, sexual orientation. That's about who you're attracted to.
And the module emphasizes this as a core part of self, right? And it's a spectrum. Heterosexual, homosexual, bisexual, asexual, pansexual, lots of variation.
It's a whole spectrum. And that
Obvious.
flows naturally into gender identity. This is different. It's your internal sense of self, who you are.
Right. And when that internal sense doesn't align with the sex assigned at birth and it causes real pain, that's where gender dysphoria comes in.
Precisely. The DSM-5-TR definition talks about a marked incongruence, leading to significant discomfort or distress. And it has to be persistent, usually at least 6 months.
But that word distress, for students thinking about empathy, what does that actually feel like for someone beyond just a diagnostic criterion?
Oh, it's often profound. We're talking intense anxiety, sometimes depression, feeling alienated or trapped. It's much more than just discomfort. Social isolation can be a huge part of it, too.
And the module points out a really important shift in how clinicians approach this. It wasn't always supportive, was it?
No, historically, there were attempts to make the person's identity conform to their assigned sex, which you can imagine was often harmful.
So what's the standard now?
Now, the standard of care is completely focused on supporting the individual's true gender identity. That's the key.
How does that work in practice?
Well, it can involve psychotherapy, helping the person navigate their feelings and experiences. Social transition is often part of it, things like changing names, pronouns. And for many, gender-affirming medical care is crucial.
Like hormone therapy or surgery?
Exactly, though it's very individual. Not everyone wants or needs the same interventions, but the goal is always the same. Alleviate that dysphoria by affirming who the person truly is.
That perspective feels really central to this module. Okay, so let's shift gears a bit. From identity, which has this core stability, to sexual function, which seems, well, more vulnerable to disruption.
Very much so. Difficulties with sexual activity are incredibly common, and often, yeah, they're tied to external pressures, life stress.
Especially thinking about, students here in LA juggling school, maybe work, relationships, figuring out your future, that pressure cooker environment.
Absolutely. All that chronic stress. It can definitely put the brakes on sexual response. It's a huge inhibitory factor for many people.
So when the module talks about sexual dysfunctions, what's the basic definition?
It's generally defined as recurrent problems during any phase of sexual activity, desire, arousal, pleasure, or orgasm. And these could affect both men and women.
The module lists quite a few specific ones: delayed ejaculation, erectile disorder, female orgasmic disorder, uh, male hypoactive sexual desire disorder, genitopelvic pain.
Right, there's a whole list, but maybe instead of just listing them, let's think about the why behind them. What's
Right, so
often driving these issues?
okay, yeah, like take erectile disorder or female orgasmic disorder. Physical causes are possible, of course.
Sure. Medical conditions, medications,
Yeah.
those need to be ruled out. But often, the module emphasizes the psychological factors,
Mm.
especially anxiety.
Anxiety about what, specifically?
Performance anxiety is a big one. Worrying about getting it right or lasting long enough or satisfying a partner.
Okay, here's where it gets really interesting. Because you might think the main cause is always like past trauma or substance use, which do play a role,
They certainly can.
but the module really highlights the impact of cultural myths and expectations.
Yes, this is so relevant, especially in a place like LA, which can be very image conscious, very focused on performance, success, maybe even a certain idea of sexuality.
You mean like pressure from media or even just comparing yourself to others?
Exactly. When people internalize these often unrealistic standards about what sex should be like, maybe how frequent, how spontaneous, how perfect, the performance they can create intense pressure,
And that pressure itself causes the anxiety.
which then interferes with the natural sexual response. It becomes a vicious cycle. The cultural expectation literally helps create the dysfunction.
Wow. So if that's a major driver, how do you treat it? How do you break that anxiety cycle?
Well, therapy is usually the first line, specifically cognitive sexual therapy, or CST,
Yeah.
and broader sex therapy approaches.
Cognitive. So focusing on the thoughts.
Precisely. The cognitive part is about identifying and modifying those distorted thoughts and unrealistic expectations about sex. Plus, improving communication between partners, making it less pressured, more open.
Is there a specific technique mentioned? I remember reading about something called sensate focus.
Yes, sensate focus is a classic, very effective technique. It's kind of brilliant, actually.
How does it work? What does it do to break the anxiety?
Okay, so the core idea is to remove the pressure of goals, like intercourse or orgasm, entirely from the equation, at least initially. Partners take turns giving and receiving touch.
Just touching.
Structure and touching focus purely on the physical sensations, on pleasure, without any expectation of it leading anywhere specific. Often, genital touch is even off limits at the start.
So you're taking the performance demand away.
Exactly. You're retraining the brain, essentially. Shifting the focus from, I have to perform or will I achieve orgasm, to simply, what does this feel like? Where am I feeling pleasure? It dismantles the anxiety piece by piece and lets the body's natural responses kind of come back online.
That makes a lot of sense, changing the script in your head. The module also mentions medications sometimes, right? Like Viagra or flibanserin.
It does. Pharmacological support can be really helpful for some dysfunctions, often used alongside therapy. They might address an underlying physiological component while the cognitive and behavioral work is happening. It's often a combined approach.
Okay. That covers dysfunctions. Now, we need to shift again. And this next topic requires real care and clarity. Sexual deviations and paraphilic disorders.
Yes, this is an area where precise clinical language is crucial. We absolutely have to distinguish between a sexual interest that's just not typical versus something that constitutes a clinical disorder.
So the module defines paraphilias first. These are intense sexual interests that are outside the norm, right? Involving unusual objects or situations or activities.
That's the basic idea. And importantly, having a paraphilia in itself is not a mental disorder. Many people have them without any issue.
So where's the line? When does it become a paraphilic disorder?
The line is crossed into a disorder only when that interest causes significant personal distress to the individual, or it causes impairment in their life, like they can't hold a job, or maintain relationships because of it, or, and this is critical, when it involves acting on urges with non-consenting individuals. That causes harm.
Distress, impairment, or harm. Those are the keys.
Exactly, that's the clinical threshold.
And the DSM lists specific examples under this disorder category. Things like exhibitionism, voyeurism, frauderism.
Which is non-consensual touching, yeah.
Yeah.
Also sexual sadism, sexual masochism, and pedophilia. It's a specific list where that distress impairment harm criterion applies.
What does the module say about causes? Is it understood why these develop?
It's complex. Like many things in psychology, there isn't one single cause. It seems to be a mix of factors, possibly neurobiological differences, learning experiences, cognitive patterns, maybe interpersonal difficulties, Genetics might even play some role.
And it mentions they are seen more often in men.
Epidemiologically, yes. These diagnoses are significantly more common among individuals who identify as men. The reasons for that are still debated.
When it comes to treatment for these disorders, especially ones involving harm or risk of harm, what's the focus?
The immediate focus becomes risk management. How do we reduce the likelihood of harmful behavior? Treatment usually involves a combination of approaches. Psychological therapy is key. Cognitive behavioral therapy, or CBT, is very common. It aims to help the person manage their impulses, challenge the cognitive distortions, the thoughts they use to justify the behavior, and, really importantly, develop empathy for victims or potential victims. Group therapy is often used too.
And biologically, the module mentioned medications targeting hormones, antiandrogens, chemical castration. That sounds intense.
It is serious and typically reserved for severe cases, often involving high risk of violence, maybe within the legal system. The idea behind using something like an anti-androgen medication is to lower testosterone levels.
Why? What does that do?
It reduces the intensity of the sexual drive, the libido. The goal isn't punishment, it's therapeutic. By lowering the drive, the compulsive urges become easier to manage and control through the psychological therapy work. SSRIs, the antidepressants, are sometimes used too, maybe for milder cases or associated issues like impulse control or anxiety.
But it also notes that getting people into treatment is hard.
Very hard. There's often immense shame, denial, and the behaviors themselves can be deeply ingrained. Unless there's a legal requirement, many individuals with these disorders unfortunately don't seek help voluntarily.
That difficulty leads into another really heavy but vital topic the module covers: sexual assault.
Yes, and it highlights a really sobering point that needs emphasis. While stranger assault gets a lot of media attention, the reality, statistically,
Is that most victims, both adults and children, know the perpetrator. An acquaintance, a date, even a family member.
exactly, significant percentages involve someone known to the victim. That's a crucial piece of understanding the dynamics of sexual violence.
And the impact is just devastating. Trauma, PTSD, relationship issues, long-term effects.
Absolutely profound. Which brings us to the necessity of addressing offender treatment. The goal there is primarily about reducing recidivism, preventing future harm.
How do they approach that? How do you assess risk?
It involves comprehensive risk assessment. And for you as students, it's useful to know about the types of factors they look at. They talk about static factors.
Static meaning things you can't change.
Right. Like the person's age, when they first offended, or their history of prior offenses. Those things are part of the risk picture, but they aren't targets for intervention because they're historical.
Okay, so what can be changed?
Those are the dynamic factors. These are the things treatment can target. Things like, is the person complying with therapy? Are they managing substance use? Do they have stable housing? Are they developing better coping skills? Addressing those dynamic factors is how you work to lower their overall risk of reoffending. It's about accountability and behavior change.
That makes sense. Focusing on what's changeable.
It's essential context for understanding the clinical and societal response to these difficult issues.
Wow. Okay, so we've really covered a lot of ground here. We went from the fundamentals of identity and sexual function
Yeah, the basics.
to the really common struggles with anxiety and dysfunction, often fueled by culture.
And then into the more complex clinical territory of paraphilic disorders and the serious issue of sexual violence.
It feels like this module really does provide that deep, necessary dive into intimacy issues that, frankly, touch everyone's lives in some way, whether directly or indirectly.
Absolutely. And for you, stepping into psychology, grappling with this material, understanding the nuances, especially that line between cultural pressure, personal distress, and actual clinical disorder. It's fundamental. It builds empathy. It helps ensure you can provide ethical, effective, and informed support later on.
Definitely essential knowledge.
Great.
So before we wrap up this deep dive, here's something maybe to chew on, connecting this back to your own environment here in LA.
Okay.
If we accept that cultural expectations about performance, image, success significantly shape how people experience sexual dysfunction, that anxiety we talked about,
Right, the LA pressure cooker idea.
then how might this specific environment, this hyper-visible, maybe performance-obsessed culture of Los Angeles, both worsen those pressures, but also potentially offer unique ways to alleviate them? Maybe through its diversity or the fluidity of identity here, something
Right.
to think about.
Ooh, that's a really interesting question. How the environment itself might hold both the problem and part of the solution, definitely something to mull over.
Well, that is all the time we have for today's deep dive. Thank you so much for joining us as we unpack this really important module.
Thanks for listening.
We're getting close to the end of the course, just a few modules left. We're excited to tackle them with you. We'll see you back here next time on the deep dive.